All right, it is now 12:30. I just want to welcome everyone. Good afternoon. My name is Olivia Henke from the New England QIN-QIO, and I'll be moderating today's webinar. Thank you for joining us for Patient-Centered Agency Response Plans to Avoid Preventable Readmissions. Before we get started, I'm going to quickly review a few housekeeping items. This call will be recorded for training purposes. I'll provide you with details on accessing the recording at the end of this webinar. The phone lines will be on mute for the duration of the presentation. I'm going to go ahead and mute everyone one more time just so no background noise gets through. Thank you. And we will take questions at the end, and I'll provide you instructions on how to unmute your line. For those who need the call-in number again, we will post that in the chat. At this time, I'll introduce today's speaker, Kathy Roby. Kathy is the Connecticut Home Health Lead for the New England Quality Innovation Network Quality Improvement Organization. Kathy is a registered nurse with over 40 years of experience in home health care. She specializes in quality management, improving home health providers' clinical outcomes, and reducing acute care hospitalizations for Connecticut home care providers. Please welcome Kathy.
Good afternoon, everyone. Well, it's a gray November day, and I don't know about you, but I haven't been able to get warm yet today. So we're going to spend some time together this morning and discuss patient-centered response plans that I hope will assist you to avoid preventable readmissions. I'm coming to you this morning from the New England Quality Innovation Network. This is our joint effort with health-centric advisors. Qualidine, working with them, we cover the 6 New England states. I hope that you will visit our website. Today's program will be posted there within a couple of days. And all of our previous webinar programs and resource materials, not only for home health, but for all aspects of the continuum, are available to you there. This is the website. If you go to the For Providers tab, and click on the home health section, you will be able to go through the website to access all of the webinars that we have done. Today, we're going to talk about creating a response plan that you can educate your patient so that they are able to identify when their condition is changing, so that you can partner with physicians to give patients accurate information, parameters to use to measure any change of their particular condition, and together reduce avoidable readmissions. This is our goal. We can identify and reduce avoidable hospital admissions with a patient-specific change in condition response plan that has physician support and patient buy-in. So how can we go about doing this? If we utilize a data-driven PDSA approach that incorporates patient-centeredness, uses SMART goals, and tracks your data with validated tools, you will certainly be able to accomplish this. And since we all know that reducing avoidable readmissions is a core piece of the value-based purchasing initiative, it's a core piece in improving patient satisfaction. This is clearly a task that we need to focus our energies on. For those who may not work in a PDSA manner on a regular basis, let's take a quick look at how we would approach this particular project using this methodology. PDSA stands for Plan, Do, Study, and Act. What would our plan be? You would begin by analyzing your own internal hospitalization data to identify the diagnoses that most often are causing those readmissions and what some of the precipitating factors might be. How would you go about doing that? What is your resource? CASPR data is usually 6 months at minimum in arrears. It will give you a specific number for what your readmission total is. It'll be risk adjusted to place you in context with your peers. And if you're familiar with Casper enough and Facile in Excel, you can use a tally report to take that raw number of your acute readmissions and hospitalization data to break it down into a patient-by-patient report. An easier and more current approach would be if you have a scrubber program attached to your EMR, then you will be able to run a scrubber report using programs like SHP, PPS Plus, Home Health Gold. These will give you current data so that today, on November 9th, you would be able to get current hospitalization data for the month of October. This would tell you then what your primary cause of readmission was and what the primary diagnoses underlying that were. Once you've identified that perhaps 40% of your readmissions were due to an exacerbation of CHF, and a contributing factor might have been that they also had COPD or that they acquired pneumonia or influenza. Having done that, now you need to think about establishing reportable parameters that would make it possible for your clinicians to teach the patients with those primary diagnoses how to recognize when they are beginning to slip ever so slightly off track. You will need to have those parameters approved by your professional advisory committee. This will enable you to know that you have backup. Identify one or more physicians that you are receiving referrals from who are represented in those specific patients that you believe will be open and amenable to helping you to support these protocols. So that's how you create the plan. Identify a patient group, a particular disease that you want to work with, create a protocol, get it approved by your PAC, and then identify a physician group to work with. So the doing part, which I've just summarized, narrowing the focus down to one particular diagnosis, a small group of patients with a common physician, using those parameters, we're now going to create that patient-centered response plan. You want to share that with the physician's group so that they can consider how they would like to support that and work with you on it. On an individual patient basis, you set SMART goals with that patient working together so that the patient and their SMART goals remain at the center of your teaching and your plan of care. Track your patient's progress toward meeting these goals with their physician. It's critical that the physician be actively involved and that you coordinate and work directly with them. Once you've invested at least 60 days into working with these patients, working with those plans, you want to collect the data on an ongoing basis at the patient, diagnostic, and patient outcome level. You want to audit each instance of emergent care or hospital admission for both cause and availability and avoidability. Once you've done that, this will provide the direction that you need in order to review and revise your teaching tools, the patient-specific individualized response plans, and the parameters themselves, so that if you need to, you can identify where and how you need to upgrade or change these tools. Having done that, you circle around to the final step, re-educating your staff, implementing the revised process. Resume your data collection and continue to repeat the PDSA cycles with staff, physician, and patient family input. Using this modality and running these cycles over approximately a 60-day time frame is what's called using rapid cycle PDSA. I've mentioned several times reportable parameters. Exactly what are those? These are significant deviations from normal ranges that relate to a specific diagnosis. They provide us clinical indicators of potential negative changes in that specific medical condition. These indicators require a response plan so that you can avoid that critical change in condition that might precipitate emergent care or even a direct admission. We need to utilize the basic nursing principles that we all have in our background to develop the plan for a specific diagnosis or diagnostic group, such as congestive failure, COPD, or diabetes. Why do I keep mentioning those three? Because these three are the three lead causes of emergent care and avoidable readmissions. In some form, be it an actual exacerbation of congestive failure itself, perhaps the CHF has been exacerbated by some other medical condition. COPD can be dramatically exacerbated by an allergic reaction, by influenza, by pneumonia. Diabetes can easily be exacerbated by any other viral or bacterial infection. So these are the core, and we need to address those particular reportable parameters that will tell us, tell the patient, tell the caregiver, we are slipping slightly off track. We need to intervene right now. So establishing the reportable parameters for each of those is going to require us to do a little research. You're going to need to consider how you're going to determine the best practice standard that you want to use. You will notice as we go through today's presentation that I am not going to specifically recommend any particular website or textbook or group, because it really is incumbent on each of you, representing your agencies, to do the research, identify what best practice standard you wish to rely on, what resource you and your PAC are most comfortable with. The physicians that you're working with may well have a best practice standard resource that they want to work with. And that's one of the best ways to open the dialogue, is to ask them what they would like to use, what would they recommend. And then once you've established those reportable parameters for that particular chronic disease entity, you're going to now coordinate with the physician to establish the reportable parameters that are specific to his or her patient or a particular patient. Then you develop the emergent response to these deviations that is intended to prevent the crisis situation by coordinating directly with that patient's physician. The purpose of this direct communication is to improve and promote the physician engagement in working with us. To do that, we are going to need to have the most professional clinical communication that we have ever exhibited. The best means that I have ever found to do that is the SBAR tool. This has been around for almost 10 years now. The HHQI folks have had this tool up on their website since the beginning of the 8th scope. If you're not currently using it, I strongly recommend that you go to HHQI, put SBAR into the search box. It will bring up the best practice package that includes reducing acute care hospitalizations, and you'll find this tool and all the instructions to teach it to your staff located there. On our QIN-QIO website, an earlier webinar from the very first 6 months of our time together in the 11th scope also has the SBAR tool, the training for your staff, and some patient scenarios that you can use. Why does this tool work? It works because when your nurses are using the SBAR tool, they are presenting patient-specific clinical data, a very brief background sketch of that patient. They are proposing potential solutions to the physician. And by doing that, they are presenting themselves in a highly professional, clinical, concise manner, which will be not only professional, but impressive and effective. Here's an example of how we might use SBAR to accomplish this. there's the words that go with the initials: the situation, the background, the assessment, and the response. Your patient, Ms. A, has had a weight gain of 3 pounds over the last 36 hours. She has sustained a 10-point elevation of her blood pressure. Respiratory rates elevated to 25. She does admit to a recent history of dietary noncompliance. What is the background? Ms. A has a history of CHF with repeated admissions for exacerbation. Each of these has been treated successfully with supplemental diuresis over 36 hours. As a nurse, what is my assessment? I believe Ms. A is experiencing or has the potential to have a repeat acute episodes of CHF. What would I like to have from the doctor? I would like to administer a supplemental Lasix dose for 2 days, instruct or visit the patient to be weighed twice daily, make at least 1 additional nursing visit with a faxed report. Establishing this as part of the standing response plan could further work to prevent any additional emergent care episodes. So that you can see, if you were to go back to the top, repeat this aloud with a watch, you can actually make this report to the physician in a concise, professional, crisp manner, obtaining buy-in, obtaining orders that you need to keep this patient at home in less than 15 seconds. Physicians will appreciate this for no other reason than you are not taking up excessive time when they are busy trying to get in to see all the patients they need to see that particular day. Here's a sample of what a CHF protocol might look like in a personalized patient emergency response plan. You are instructing the patient that they are to weigh themselves daily, that if they gain whatever X amount of weight in 24, X in 5 days, they are to take whatever additional dose the doctor has ordered and then contact the physician for additional orders. Teaching them to take their own blood pressure every day before their morning medications and to notify the physician for specific ranges. And obtaining those PRN nursing visits on the orders, bearing in mind that we are expected to give a reason for PRN orders, and written this way, you are clearly accomplishing that, because you've said exactly why you want to go out and see that person. What would be the patient action plan related to this? What are the SMART goals? The very first thing is, as we said in the PRN emergency plan, patient needs to be taught and encouraged to take their weight daily at the same time, immediately after the morning void. They need to be taught how their medication works and why taking the additional medication as instructed is going to help them. We want to see them competent and compliant, motivated to check their weight and their blood pressure on a daily basis, and then pursue diet, exercise, and medication instruction and achieving compliance. What are the tools that we need to work with them? A personalized emergency plan that you can leave in the home that has the response medication changes written right in it, has specific instruction that is absolutely built to reflect that patient's own condition is going to be critical. Do you remember the Stop and Watch tool? That's also part of Home Health Quality Improvement's website of their DPIP on reducing hospitalizations. We're going to take a quick look at these. You also want to focus on reinforcing with your patients every accomplishment they make. When they can show you that calendar page with their daily weight and their daily blood pressure on it, when they can demonstrate how to take that blood pressure on themselves and on their spouse or their caregiver, that reinforcement of their success is going to make all the difference in getting them to continue to work with you. I've included here a slide that you can use to actually train patients. The learning level is actually at a 5th grade. This has been rechecked, and it comes from a textbook, so that you can use this definition to work with your patients, and you can use it to set some of the basic parameters that you're going to want to use. This is the My Emergency Plan. As you can see, again, the learning level, language level is 5th grade, and we have on here very specific instructions that you can customize. If you are teaching your patient to take their blood pressure in the middle of the page, you are able to see that they are to call you when their blood pressure is above a certain amount. You can customize it to add on there when my blood pressure is below a certain number, when my weight is up by whatever. These are things that you can work with, that you can adapt so that it is appropriate to your patient. This is the Stop and Watch tool. This is also, I apologize for it being a bit fuzzy. This one is on the HHQI website. It's also part of the Interact package. But this is a wonderful way to include the home health aides in the process of working with the patient, because you can train your home health aides to follow carefully their patient and to call you. This is clearly within the scope of practice for a home health aide. We absolutely are encouraged to teach the home health aide to follow these tools. They are going to recognize, because they spend far more time with the patient than we do. A caregiver can be taught this, whether it's a private hire live-in, a PCA, a homemaker companion, or a family member. This is intended to be used by that level of individual so that they will recognize, Mom, Dad, my patient, my friend, just doesn't seem to be quite right today. They're slower to answer. They're not making sense when they talk to me. They just seem to need help getting out of the chair more than they ever did. These are things you want to hear from them about. Giving them the Stop and Watch tool, giving it to them with your name and your phone number and when to call and how to get a hold of you is going to make a tremendous difference in keeping your patients out of the hospital. We can't do this without significantly increasing physician engagement, physician buy-in. Our physician counterparts are clearly being looked at in terms of their role in emergent care and acute care hospitalizations. It is now an outcome measure for them, something that they need to closely watch. Their participation in accountable care organizations and many of the new and emerging demonstrations for payment models are expecting them to work with everyone in the continuum to keep these emergent care and readmissions as low as possible. In order to accomplish that, they will now be more motivated than ever to work with us. So consider, when you admit the patient, calling this physician and saying, your patient, Ms. A, has had 3 emergent admissions in the hospital for CHF. Each time you treated her with 20 milligrams of Lasix twice a day, in addition to her baseline dose for 3 days, and then weaning down with daily weights. I would like to include that in my start of care orders. Once you've got that in there, it's going to be much easier for you to create that personalized emergency response plan, include that action plan, include the assessments you want the patient to learn to do, the daily weights, the blood pressures. By doing that, you've now begun to work more closely with the physician. Rather than try repeatedly to get them on the phone, consider faxing periodic reports to the physician. And when you are ready to discharge this patient from your services, emphasize the successes by saying in your discharge summary, Ms. M had 3 emergent observations at Johnson Hospital for exacerbation of CHF from this date to this date. We are discharging her today with no emergent care for the last 90 days. She's actively following her CHF protocol. She knows when to contact you for intervention. By doing that and replicating each patient's success with another, by reminding the physician each time of the previous successes with other patients, is going to encourage and motivate them to give you the next set of what-if orders for another patient. On one of the HHQI best practice packages, they said this to us about emergent care planning, that if we educate physicians in the patient emergency care plan, we communicate the purpose, which is to keep the patient in the right setting, to educate the patient to understand who to call when, and that we are focusing on patient self-management, we can have effective personal emergency planning to reduce unnecessary physician office and after-hours calls and emergent care episodes. You can expand your program. You can create similar protocols for each of your other leading causes of readmission. As I said, we know that the 3 leading causes are CHF, COPD, and diabetes, along with any of the other related issues that may precipitate an exacerbation of one of those core 3. By repeating the rapid PDSA cycle process, you can then identify some of these other causes of readmission, some of these precipitating triggers. You can then create and implement protocols to address those across your patient populations. And I cannot say again, can't say it enough, market your successes to the physician practices you work with. Nothing breeds success like more success. Each time that you succeed in discharging a patient from your services to independent self-management at home, calling the physician less often, calling appropriately, not popping up in the ER on Christmas Eve, you will be your physician practice group's new best friend. So I hope that you found that to be helpful for you. Getting this type of a program up and running is not an easy task, but if you focus on working this process as a PDSA program, repeating it over and over as a 60-day rapid cycle, you will begin to see results. I would encourage you to look at this as a supportive reason for having a scrubber program. I will not ever endorse any one particular program, but there are many of them out there, and they can provide you with the data that you're going to need, not only initially, but in an ongoing basis. Supporting the Million Hearts campaign has always been an integral part of everything that we do in this 11th Scope of Work project. We are working, hopefully together, with our physician partners to reduce the risk of cardiac incidents. We need to improve heart health across the continuum. There are so many ways that you as home care providers can participate in this. Internally, you can continue with your healthy lunch once a week, with a lunch and learn on any particular topic, with a noontime walkers group. You may have heard a little noise in the background. My office is near the stairwell. Our noontime walkers were heading off down the stairs. All of our 4 flights, down they go and back up again. A couple of trips every day at noontime. They go as a group, not too fast, just enough to get their hearts moving, get a little exercise, come back and have lunch, and go back to work refreshed. No cost to anyone, no cost to your agency. but a terrific way to support heart-healthy risk reduction. What about immunization? Yes, it's the 9th of November. Most people focus on getting their flu shots in October. It is not too late. Remember, it's a value-based purchasing data collection item. Have you been able to achieve 100% of all eligible agency employees have received the flu shot? This is a critical thing. It is cost-effective. It is going to make a difference for you. Consider the cost of sick time. Consider the impact of one in-house staff member coming to work with the flu because they didn't get a flu shot and exposing every single person who walks through the door to their virus. Clinicians, nurses, therapists, home health aides coming in for their schedules or their paychecks, your administrative support staff. Let that virus loose in your billing department and cash flow comes to a grinding halt. Consider running a company flu clinic. It is not too late. Russ and I are planning a new program in January to reinforce that flu shots can be given to your patients and your staff right up into the middle of January. We hope you'll join us for that program. We hope that you're out there encouraging your staff to get their flu shots, get a little fresh air, get some exercise, and reduce their risk to have a heart-related incident. We would really like to hear from anybody that's on this call today, anyone that's been working on a project to reduce readmissions and reduce emergent care. What are you doing that's working well? If you're not comfortable sharing with a group, being actually on the line and doing part of this webinar, if you would simply send us a quick email telling us about what you're doing or just giving us your name and your number so that we can call you and then we can share those ideas. By working together, sharing ideas and helping each other, everyone's outcomes will improve. We can share those processes, your suggestions, your ideas on any one of our monthly webinars. So if there is a topic you would like us to focus on, if there's a process or a project you're doing that you'd like to share, perhaps get some input from the others on the line about what else you could do, some help resolving a problem. That's what home health providers always used to do. We reached out to one another, not just to our patients. I'd really like to see us resume that practice because I know that there's a solution to every problem we face if we could just come together and talk to each other again. The Home Health Quality Improvement website has a variety of resources. There's HHQI University, where you will find a series of 3 programs on the QAPI process and implementing and documenting, tracking your PDSA cycles. In December, they will have their regular quarterly webinar. The date is December 15th. The topic has not yet been announced, but it soon will be. All of their previous webinars are also archived on their website. There is a tremendous amount of resources available to you there. I encourage you to go there today, cruise around, check it out. If you're on the line here with us today, have you registered to start collecting your data on the cardiovascular LAN? If not, please call your contact for this 11 Scope of Work project. We will help you to get registered. We'll help you to select an outcome and to begin collecting some data and implementing those rapid cycle PDSA projects. I hope you found today's topic helpful. I work with agencies and providers in Connecticut and other states on a regular basis. Any agency where we have begun to implement this process, where we put these parameters into every set of start of care, resumption of care orders, we have seen significant regular improvement in reducing their hospitalizations and emergent care episodes. It's very important. It's a critical step. So do a little research, pick your resource, set up your parameters, and write your protocols. Get them past your PAC, pick a physicians group, and get started. If you need help, call the contact person from the QIN-QIO for your state, and we will absolutely work with you one-on-one to help you get this going. I'd like to throw the floor open. If anybody has specific questions for me, I'll be happy to try to answer them if I can.
So thanks, Kathy. If you'd like to ask a question, you can press #6 on your phone to unmute your line, or you can pose a question in the chat box. Please just make sure to send that chat to all participants. So again, #6, or you can send a chat in the chat box to all participants.
Okay then, I don't see anyone putting anything into the chat box, and I haven't heard any questions yet. We do have one more slide here with the email addresses for the 11th Scope of Work QIN-QIO contacts for each state. I'm here in Connecticut. There is someone in every state: Danielle in Maine, Georgette in New Hampshire, Brenda in Rhode Island, Jill in Vermont, and Karen in Massachusetts. The email addresses are there. Please do reach out to us. We are very happy to work with you anytime.
I see there is a question in the chat box coming out, a link to download. And yes, these slides were available in the Day of Details email that we sent out to all registrants. And again, we will be sending these out again in a thank you email to all registrants as well. If there are no further questions or chat, I just want to thank everyone for a great discussion, and I just have a few last-minute announcements before we end the call today. When you close out of this webinar, an evaluation will automatically pop up on your computer. You could please fill that out. We would greatly appreciate it. If you don't have time to fill out the evaluation right now, or you're currently sharing a computer with someone else, you'll receive an email tomorrow morning with a link to the evaluation, as well as a link to the event page on our website. The PowerPoint presentation is already posted on our website, and within the next week, a recording and a transcript will also be added. Please be on the lookout for emails about our next webinar. Thank you again for attending. Thank you to Kathy for a fabulous presentation, and I hope everyone has a great day. Thank you.
The leader has disconnected. The conference will be terminated in 5 minutes.